Bismillah ar-Rahman ar-Rahim. We will continue with research design. We will be talking about research designs. A good research strategy should always lead to establishing a solid design. It means that good thinking about how to do the research. It originates from the relationships between the predictor and outcome variables, hypothesis testing, and time of exposure. Thus, studies are grouped as observational and experimental. Observational, these are descriptive and analytical. Descriptive: case reports, case series, community need assessment, epidemiological description of disease occurrence, descriptive cross-sectional community surveys, and ecological studies. While analytical, it involves hypothesis testing, cross-sectional studies, case control studies, and cohort studies. The other type is experimental, where we interfere and we assign groups with intervention and groups with control and groups with placebo and so on. Let's begin with descriptive studies. They are aimed at generation of hypotheses, describing the existing indicators and measure the variables on reality. It will include collection, analysis, interpretation of quantitative or qualitative data that we gathered by questionnaires, interviews, records, statistics, to describe population or groups. Case reports and case series. Based on records or series of cases or one case with the disease, it mainly involves the specific case or cases with all descriptive statistics. While these cases or case can be used for teaching and review purposes, they can also have a role in research. They may be the first description of a clinical condition. After that will come many cases or the effect of a treatment. A case report typically describes a single patient. It is normally the report of something that has happened or has been observed. That is, the report is retrospective. Case reports normally focus on the manifestations, clinical course, prognosis, or outcome for the patient. Descriptive study also community need assessment or diagnosis. It provides baseline data, identify existing community problems, needs, and types of risks. Epidemiological description of diseases, also disease occurrence. We collect data on occurrence and distribution of disease just for the knowledge. We need to know the rates, the ratios in populations by characteristics of individuals and familial patterns, place, causes, and so on, and time. Okay. Descriptive cross-section community surveys. These type of studies will describe a section of population with the purpose of providing prevalence rate at a point of time, with assessment of conditions by population character. For example, when we do the CAP studies, knowledge, attitude, practice studies. Ecological studies, the unit of observation and description is family, school, tribe, village, town, and so on. Why we use these? Analytical studies, descriptive, analytical. We test hypothesis, etiology. Is it related to this factor, that factor, risk factor? We establish causes of diseases. Look for association between exposure and risk factor to a risk factor and occurrence of a disease. The basic approach: developing testable hypotheses, control for extraneous variables that can confound the results. Three types: cross-sectional studies, case control studies, cohort studies. Cross-sectional. The investigator measures exposure and disease simultaneously at the same time in a representative sample of the population. So, at a point of time, we need to know the prevalence. So, at a point of time, or maybe over, for example, from the beginning of the year until the end of the year, we go and we see these cases, what happened, the prevalence of diabetes, for example, or anything else, and the factors related, whether they were exposed to anything, whether they have risk factors, advantages. If a probability sample is used, it means involving randomly selected sample. Generalization is possible. Measures the prevalence, not incidence. More appropriate in chronic disease for permanent characteristics of subjects, not short duration of rare disease. Less costly, good for screening conditions. Useful for many purposes. The health system policy, prevalence of disease, very well suited for describing variables, their distribution patterns. All measurements are done on single occasion or short period of time. Prevalence of any designated variables can be reported. If the sample is drawn from a diseased population, this would be a case series study that describes the disease in this section of population, which may have different levels of exposure to risk factors. So we describe the cases, but they all share the same symptoms, the same diagnosis, and they might have different exposure to risk factors. Serial surveys, this entitled conducting a series of cross-sectional studies over time on the same population. What we measure in cross-sectional studies, the prevalence. Prevalence measures how much of a disease or condition there is in a population at a particular point in time. It gives a figure for a factor, disease, injury, health status at a single point in time, point prevalence, or time period, period prevalence. Period prevalence provides the better measure of a factor since it includes all cases between 2 dates, whereas point prevalence only counts cases on a particular date. It is a measure of disease that allows us to determine a person's likelihood of having a disease. It's reported meaningfully as the number of cases as a fraction of the total population at risk, and can be further categorized according to different subsets. For example, at recent study showed that prevalence of obesity in a group of adult women was 55% at the time. This is a retrospective. We go back in time. Investigation of the histories of exposure to suspected risk factors by cases and controls. Cases means they are diseased, they have this diagnosed with disease, and we take controls, they don't have the condition or the disease. Analysis is to determine if exposure to risk factor was different for cases and controls. So risk factor is the one that potentially increased the probability of occurrence of the disease. It happened before disease or onset or occurrence. For example, smoking, infection. If a greater proportion of cases than control give a history of exposure to risk factor of interest, this factor can be suspected as a causative one. This diagram or figure, cases of lung cancer, controls, no cancer. So we go back to see if they had been smoking before. So we will have lung cancer with smoking status, no smoking, and controls will have them also smoking, no smoking. What we measure in case control, odds ratio. A study looking at breast cancer in women compared cases with non-cases and found that 75 out of 100 cases did not use calcium supplements compared with 25 per 100 of the non-cases. So what we do, how we measure it? We develop a table to display the data. We calculate odds ratio of or odds of exposure in cases and non-cases. We calculate the odds ratio, and we explain the difference between the prevalence and the odds ratio. So here we have the 2x2 table, which is about the odds ratio. The table at the left, we have it with numbers. The table at the right, we have it with A, B, C, D. No number, just to show us how we do the odds ratio. And the meaning of odds ratio, it's about the odds or likelihood, the odds of getting cancer, breast cancer, among women who have no calcium supplement compared to those women who have calcium supplements. So after we calculated with the two methods, at the right, if you see it, A divided by C divided by B divided by D, or A between two brackets, A multiplied by D divided by B multiplied by C, it will give the same answer. So the odds of getting breast cancer among women with no calcium supplement is 9-fold those women with calcium supplement. Another example, smokers, no smokers, lung cancer, no cancer. In the case of lung cancer, it is the ratio of the odds of lung cancer in smokers divided by the odds of lung cancer in non-smokers. By either way, we get 3, the odds ratio equals 3.24, which means that the odds of getting lung cancer among smokers is 3-fold, 0.24, those with who were non-smoking, 3-folds. Case control studies, how we select cases. Inclusion, exclusion criteria, we should always be aware of it. Source of cases might be hospital admissions, outpatient clinics, survey reported cases, newly diagnosed cases, deaths with complete records. Controls, it might be from patients in hospital with different diagnoses or they don't have the condition we are studying. Sample from the same population. Controls may be matched by cases. It means that I take the case around 30 and I will get the control around 30. So we match them by age, sex, socio-demographic status. But it's not recommended to do a lot of matching or even matching, because matching can eliminate confounding effect of variables, achieve comparability of cases, controls, and ensure that sufficient numbers will be available in categories of interest. But if we, as I said, limit the matching for not so many variables. Advantages of case control studies: feasible in rare diseases, efficient, requiring smaller sample than cohort studies, no need for follow-up for disease occurrence. What are the disadvantages? We cannot calculate attributable risks, no incidence rate, no population at risk as denominator. These we'll know about in the cohort studies, but it's not that disadvantage because it is specified for case control, it is specified for odds ratio. That's what we need to do it. So I would not consider it a disadvantage. Temporality or cause effect may not be determined. For sure the risk lead to disease. This is regarding the cause effect. It means that which one is happening before, because there might be a lot of recall bias by those cases. Did they smoke before getting the cancer or not, for example? So there will be chance of bias in selection cases, controls, recall bias on exposure, death survival difference exposure, effect of cases selected in hospitals with selective rules, admissions, and misclassification bias. Measurement cannot exclude the effect of other risks. So how we enhance validity of case control studies? Cases representatives matched on studied variables, multiple good control groups, exposure status does not affect selection of cases or controls, and we try as much as possible to eliminate biases as we can. Let's go now for cohort studies. These are two types, prospective or retrospective. Prospective, following or follow-up. The researcher starts with a reference population, some of whom are exposed to the effect of risk factors and some are not. But both groups are followed over time to see if any develop a disease or a condition. So cohort, what is a cohort? Is a group selected of selected people, subjects, cohort, followed over time. A cohort may be community, subjects, birth, military, marriage, diagnosed, treated patients, and so on. That's what we call it, cohort, group of people. How we measure? What we measure in cohort studies? Incidence. We measures the rate of occurrence of new cases of a disease or condition. It's index of disease frequency. How frequent is the disease occurrence, new cases? It is based on the total population at risk who were at time of entry free of disease. So they were free and they developed the disease. So this is a new case. It is a ratio or probability of developing disease among all members initiated. So new cases divided by population at risk per 1,000. Incidence is the number of instances of a factor, disease, injury, health status during a given period in a specified population. Also about incidence, can tell us how many cases of a particular factor have been suffered by a specified population. It's a measure of disease, allow us to determine person's probability of being diagnosed with disease. Incidence is usually expressed as a rate, something that is measured within a set numbers of people and in a time period. Also, in cohort studies, we measure relative risk, effect, RR. Relative risk, dividing incidence in one group exposed by incidence in the other unexposed. And attributable risk, AR, the difference between the incidence in exposed and unexposed. What are the advantages of relative risk? Possibility to determine cause-effect relationship. Less bias about the awareness of disease status, can disclose other diseases. Less selective recall bias. Estimate attributable risk to risk factor. Can be generalized once being having probability sample. Disadvantage long term, time consuming, expensive, large sample size, not fit for rare disease, serious problems of dropouts, may affect the validity if more than 15% drop out. Withdraw among investigators. Confusion may come from change over time, surrounding conditions, and the Hawthorne effect when the behavior of subjects is affected by the study. Retrospective cohort study. The researcher looks into the available records, for example, and then restructure the exposure to a suspected risk factors, exposed versus unexposed, and then follow these patients over time retrospectively to see if any have developed the disease or the outcome of interest. Disadvantage of it: relevant results may not be available or incomplete, and we may not be sure if subjects were free from diseases at start of comparison. So we will go now to experimental design. Researchers assign exposure variable to subjects and withhold the exposure from other subjects, manipulate. This design involves controls, randomization, matching, intervention, pre-test, post-test. Why we do that? We assign and withhold the predictor or exposure variable. We need to know the effect, for example, a treatment or intervention. Randomize subjects to experimental and control group, control confounding, spurious association, to ensure temporality. Temporality means that the exposure should occur before the outcome. Which variable is a consequence of the intervention? We might replicate the findings, and often we provide this designs provide the strongest evidence in support of cause-effect relationship and basis for clinical and public health policy. The randomized controlled clinical trials aim to improve existing treatment, for example, or to replace them with new and better ones. Controlled clinical trials are designed to help us learn more about the positive and negative effects of treatments, efficacy and safety. What are the phases of clinical trials? Clinical trial is only done when there is a good reason to believe that a new test or treatment may improve the care. So before clinical trial, tests and treatments assist in preclinical research done with people. No, done with no people. It means not done with people. It's a lab tissue or animal. Preclinical research is done with no people, lab tissue or animals. It will assess the features of tests or treatment. The research may aim to learn if a device is harmful to living tissue, learn more about the chemical makeup of a drug. So after preclinical research, tests and treatments go through a series of clinical trials that we will be talking about with 5 phases. Phase 0. The first clinical trial done among people. They aim to learn how a drug is prescribed in the body and how it affects the body. A very small dose of drug given to about 10 to 15 people. Phase 1. Find the best dose of a new drug with the fewest side effects. Will be tested in a small group, 15 to 30 patients. Start giving very low doses, higher doses given to other patients until side effects become too severe or this desired effect is seen, and the drug may help patients. But phase 1 trial are to test the drug's safety. If a drug is found to be safe enough, it can be tested in phase 2 clinical trial. Phase 2 trials further assess safety as well as if a drug works. Drug is often tested among patients with a specific type of disease in larger group of patients compared to phase 1, with new combinations of drugs and are tested. Patients are closely watched to see if the drug works. The new drug is rarely compared to the current. Phase 3, compare a new drug to the standard of care drug. These trials will assess the side effects of each drug, which drug works best. Enroll 100 or more patients, which is randomized. It means that patients are put into a treatment group called trial arms by chance. Randomization is needed to make sure that the people in all trial arms are alike, which led scientists to know that the results of the clinical trial are due to the treatment and not differences between the group. So the computer will make this task, assign people to. Phase 4 trials testing new drugs approved by the FDA, tested in several hundreds or thousands of patients, allow better research on short-lived and long-lasting side effects and safety. Some rare side effects may only be found in large groups of people, and they can learn more about how well the drug works, and it's helpful when used with other treatments. This is another study, clinical trial on physical activity and type 2 diabetes. Exposed group, control group, exposed group, control group for body mass index and for hemoglobin A1C. As we see, the exposed group to physical activity has better body mass index, which is normal, around 25, and the hemoglobin exposed group to physical activity, hemoglobin A1C, is also around 5.5, which is normal, compared to what? To control group, who has not been exposed to physical activity. Also, this table gives you hints about each design.